Hey everybody, welcome back to the ECG channel. My name is Reed, and today we're going to be going over the ECG diagnostics and some of the criteria associated with acute pericarditis. Don't forget that you can head down into the description and download the PDF documents. I store them now on Patreon. It's a little bit easier organizationally for me, and so join for free. You can download all the PDFs. Everything stays free and accessible. And yeah, let's jump into it. Don't forget to subscribe to the channel. So pericarditis. This is a difficult topic. It's a scary topic. It's often misdiagnosed in folks that are having a myocardial infarction and vice versa, because some of the ST changes that we see in pericarditis are going to be very similar to that of a myocardial infarction. But there are some key differences that we can talk through in today's lectures that you can better understand the nuances of the diagnostics of EKG for pericarditis. Okay. So the first thing I want to do is just take you, as always, to talk a little bit about anatomy, because if we can understand the anatomy and some of the physiology of pericarditis, we can then better understand how that is going to link to the EKG changes, right? We need to link the structure to the function. And so if I zoom in on this heart, remember the pericardium or the pericarditis is inflammation of the pericardium, right? Itis is inflammation, and pericardy is around the heart, meaning the pericardium. So the pericardium is a two-layered set of connective tissues. It's got this visceral pericardium, visceral just meaning it's hugging the organ, right? So this is in black. We're going to call this the visceral pericardium. Some people call this the serous pericardium. And then we're going to have continuous to that, but it kind of folds and comes back around, is what we would call parietal pericardium, right? This is the parietal pericardium. Sometimes it will be known as the fibrous pericardium, right? It kind of anchors the heart. It gives it a nice structure so that it can beat, right? And so in between those two layers, you've got this, we'll color it blue here, and that is the pericardial fluid, right? And so that allows for nice lubrication between these two layers so that when the heart beats, it can move freely and with the most efficiency to pump the blood to our heart. And so in pericarditis, there is the features of acute pericarditis, and there's also complications of acute pericarditis like cardiac tamponade that we'll talk a little bit about, because there are some interesting EKG features with that. But pericarditis is essentially, as you can tell by the name, inflammation of this region, right? And this region surrounds the most epicardial region of the heart, right? And so anytime there's inflammation of the pericardium, there's a risk that there's also inflammation of this most superficial layer of myocardium that's hugging right up against it. And we would call this the epicardium, right? So there can be some epicardium or epicardial involvement, right? And why does that matter? And why does that help us understand the diagnostics of acute pericarditis on ECG? Well, if I come over here to this chart, what this is, let me just draw you out. If I took a slice, say I took a slice, transverse slice right through this heart, right? Maybe something like this, right? I'm trying to make it 3D. Take a transverse slice, I cut through. All right, imagine you're just cutting through my chest, right? In this person in anatomical position, I would get this, right? And so I've got it labeled here for you. Let's talk a little bit about why it matters if we get inflammation of the epicardium that might be caused by pericarditis, right? Pericarditis is caused by all sorts of things, viruses, autoimmune, malignant. We're not going to go into that. We're going to go into what you see on the ECG and acute pericarditis. So remember that the QRS and the T wave, whenever I draw them, I'll draw them right here. We get a QRS complex and we get a T wave, right? Our QRS is our depolarization, our T wave is our repolarization. And remember that they go in the same direction for a reason. So these right here are our Purkinje fibers. These are the Purkinje fibers, right? And these Purkinje fibers, remember, are the fibers that bring the signal from the AV node down through the ventricles to depolarize the ventricles. And they run on the endocardial surface. And why does that matter? Well, the endocardium is where the initial activation of ventricular depolarization occurs. So if you think about what direction depolarization occurs, it occurs from endocardium to epicardium, right? Because of where the fascicles are located. I'm just going to draw them on the left ventricle right here for this example. And that wave of depolarization is what causes, you guessed it, my QRS complex, right? So that's our QRS complex. And then what's interesting about the heart is that repolarization occurs in the opposite direction from epicardium to endocardium. And you might be saying, but Reed, why, if it's going in opposite direction, if these two waves of signal are going opposite direction, why do we have a QRS that's upright and a T wave that's also in the same direction? Wouldn't they be opposite? Well, remember that if I drew my cell wall, this is my cell wall, remember that depolarization, I'll draw it in green, depolarization is sodium, which is a positively charged ion, rushing into the cell. And remember that repolarization is potassium, which is a positively charged ion, rushing out of the cell. So these are two opposite electrical activities, meaning positive going in for depolarization, positive coming out for repolarization, and they're happening in opposite directions, which allows for us to see a same direction of deflection on the QRS. So that's why that happens. Let's talk about what happens when you start to disrupt this system, right? Pericarditis is going to disrupt the system because we're going to be causing inflammation in the most epicardial portion of the heart, right? The way I can best explain this to you is, one, we're going to have inflammation all throughout the pericardium, which is going to cause inflammation throughout diffusely the most superficial area of the myocardium, right? So what we will see on the EKG, what we will see on the ECG is, one, the changes will be generally diffuse, right? Because it is, causing inflammation throughout the myocardium. So you'll see this in pretty much all of our leads, okay? Whereas like an MI, you're going to see it in very, anatomic leads. Oh, this is lateral changes. This is inferior changes, right? The second thing I want you to remember is that whenever I look at this QRS complex, I want you to remember the action potential of a cell. This is really, really, really important, okay? So if I overlay an action potential of a cell, it's going to look something like this, right? So remember, we have our depolarization, and then we get this point here, and then we have repolarization, right? Does that sound familiar from early learning in medicine, right? We've got phase 0, which is depolarization. You've got phase 1 here. You've got phase 2, which is that flat line. And then you get phase 3, which is repolarization, right? And I overlaid it with time on our QRS complex, right? So when we get this depolarizing force, we also get this QRS complex, right? And the same thing with when we get the repolarization, we get our T wave. And remember that this phase 2 here is this most isoelectric portion where there is no net change in either cations or anions moving in and out of the cell. There's no change in that transmembrane potential because we have, what do we have? We've got calcium coming into the cell, right? And at the same time, we've also got potassium heading out of the cell, and it kind of balances out. And that is why we have this isoelectric ST segment in a normal ECG. So remember, this is the ST segment, right? So in a normal ECG, that phase 2 is responsible for the flat ST segment, okay? However, in pericarditis, what you'll notice is because of all of this inflammation in the most epicardial region, it actually, well, because of this inflammation, right? Inflammation causes membrane dysfunction. It causes these voltage-gated ion channel dysfunctions. And ultimately, this is going to occur in this epicardial region. And so that changes the ability for the action potential to be as kind of baseline or defined as it usually is. And the phase that it is most affected is phase 2. So phase 2 is most affected. So what segment are we in the ECG are we going to see that is most affected is our ST segment, right? So when these cells get inflamed or injured, we see phase 2 does not become isoelectric. And what we end up seeing is during what we would normally see of phase 2, you get a voltage gradient or an electrical gradient that is in the direction of those injured epicardial cells, right? And so you get a voltage gradient in that direction. Well, if there's a lead there, what are we going to see? We are going to see a positive change in our ST segment, right? So our ST segment is going to be elevated. So the first thing we're going to see on an ECG is we're going to see diffuse ST segment elevation. Okay. Now, a couple things about this ST segment elevation. It's going to be something that we would call concave, meaning that if I drew my QRS and then I drew my ST segment, I guess I got to draw it elevated because I'm giving you that example. If I drew my ST segment, so here's my QRS, my ST segment is going to be sloping in that direction. It's kind of concave, right? So it's a concave ST segment. Usually, the ST segment elevation is maybe 25% of the T wave, right? So it's not going to be, the ST segment is not going to be elevated to more than generally 25% of the amplitude of the T wave, right? So these are all kind of things that you're thinking probably features of pericarditis, right? So we've got diffuse ST segment elevation caused by this voltage gradient in the epicardium that we said affects mostly phase 2 of that action potential, which is correlated to our ST segments. It helps us, determine why is the ST segment the culprit on our ECG. Okay, so that happens. It's diffuse. We will see no reciprocal changes. There's going to be no reciprocal changes, meaning that in an MI, you're going to see lateral changes with reciprocal inferior changes. That does not happen here, but you will see the opposite in AVR. However, AVR will have ST depression, right? So AVR is going to have that ST depression. So that's the only lead that you're going to see that has ST depression. Why? Well, imagine if I go back to this picture here, remember that here is all of the pericardium that travels all the way around the heart, and AVR is kind of getting the opposite forces of everything that we're going to see, right? Everything's kind of heading in that direction. AVR is just kind of the oddball, and they're getting all the opposite forces, right? So AVR is going to be the opposite. You're also going to get some other ECG changes. You're going to see is, put it right here, we're also going to see, we'll label this number 2. You're also going to see you're going to see PR depression. So you're going to see ST segment elevation. You're going to see PR depression. We'll go over that, what that looks like on the ECG. And then lastly, you're going to see something called the Spodek sign. And the Spodek sign, if I directed you over here, it's when the TP segment, is down sloping, right? So from the end of the T wave to the next P wave is downsloping. So it might be something like this. You might have a P, and then we've got our QRS, and this is pericarditis, so it's elevated. And then you get a downsloping to the next P, right? So it's a little bit of this downsloping here of the TP segment, okay? So those are some of the ECG features that you're going to see in acute pericarditis when the epicardium is involved. You can have pericarditis when the epicardium is not involved. It's a little bit more contained. It may be more chronic. So this is obviously not every single type of pericarditis is going to have this, right? Pericarditis ultimately is not diagnosed solely on the ECG. It's diagnosed based on the clinical features. It's a largely a clinical diagnosis, diagnosis of exclusion. And so it's definitely a hard concept. But let's go over some example ECGs and talk a little bit about what makes these ECGs think of pericarditis. So here's our first one. you'll notice we've got a narrow complex rhythm. We're not going to go through the whole ECG here. They've got a sinus rhythm, right? If I zoom in, you see you've got these P waves that are conducting to QRS complexes. P waves are going to the QRS. Our P waves are upright in lead 1, and you can see they're a little upright in AVFs. This is a sinus rhythm. And so what I noticed right out the gate is I've got some ST segment elevation in some leads. And so I think, oh my gosh, maybe is this chest pain and MI? But you'll see I've got ST segment elevation in lead 1. I've got ST segment elevation all the way through a lot of this ECG, right? Got ST segment elevation in lead 3, in lead 4, in lead 5, V6, AVF, AVL, lead 1, lead 2, lead 3. It's throughout the strip, right? So this is, I think some of the labels got cut off. This right here is lead 1, and this right here is lead 2, and this right here is lead 3. So we've got diffuse ST segment elevation. Let's take a look at that ST segment. Well, you can see this nice concave up, this concave ST segment, right? It's nice and concave. You've got, if you look here, sometimes in lead 2, you can best see some PR depression, right? So here's our baseline, and then you can see the PR is a little bit depressed. And you can even see a little bit of that downsloping TP segment, which is that spotic sign, right? And so you might think in this patient, if it's positional pain, you can see here the vignette, that's a 20-year-old with chest pain. You know, they're not in the demographic to have an MI. They surely could if they had some anatomic variations that might put them at higher risk or some genetic abnormality. But in this case, you know, do they have a history of recent virus? All those things. You got, here we've got our ST depression in AVR. Sometimes, you know, interestingly, you can see ST depression in V1. Sometimes in V1, you can also see ST depression. Not always, but usually ST depression, mainly in AVR, but sometimes you can see in V1 too. So that is our first example of pericarditis. Remember, this is a very often missed diagnosis. So the ECG is just adding or subtracting data from what you think is going on with the patient, right? This is not the end all be all. This is another example of maybe one that's not as obvious, right? So we've got a sinus rhythm here. It's fast. And you'll notice that we've got, right out the gate, we've got some ST segment elevation, lead 2, lead 3, lead AVF. When you see like 2, 3 in AVF, you're probably like, man, is this an inferior? Like, is this a right coronary artery, right? We've got even this lateral elevation. Is this a right coronary? And I want you to remember that in RCA infarctions, usually in RCA infarctions, lead 3 ST segment elevation is greater than that of lead 2 because the right coronary is supplying that right side, which lead 3 is capturing more of. In this case, you don't see that. So you might think, I wonder if this is pericarditis. And you look and it's pretty diffuse changes. You can see some of that same concave shape. You can see a little bit of that spotic sign where you got downsloping TP segments. And maybe even if I drew out the baseline, you would see maybe even some PR depression. Right here's my baseline. You can see that PR segment's maybe a little bit depressed. You can see the ST segments are not elevated wildly compared to the T waves, right? Remember that 25% rule. So this is another example of pericarditis. Ultimately, like I said, a diagnosis of exclusion, and sometimes you do the ischemic workup. You get the troponin labs, the cardiac enzymes. You do serial ECGs. You treat with, in this case, it would be an anti-inflammatory, or you treat the underlying cause. If it's a malignancy or autoimmune condition, you want to treat that cause of inflammation. But a lot of times these are diagnoses of exclusion, so very difficult. I wanted to show you quickly an example of a myocardial infarction and how it's different. So here is this. I want you to notice that we have an anteroseptal MI here. So we've got an anteroseptal STEMI. And I just want to talk to you about why this is different than pericarditis. So anteroseptal, septum is V1, V2, interior is V3, V4. And if you notice here, we've got some pretty significant ST segment elevation. That ST segment elevation, though, it is convex, meaning it's kind of curved in the opposite direction right? So this is a more convex shape. Something else that you see is when you get an anteroseptal MI, you see reciprocal ST depression that is opposite, right? So you get these reciprocal changes that you don't really see in pericarditis. You can also see here, you can see AVR does not have ST depression. So in MIs, when you get ischemic or dead myocardium, you're going to also be affecting depolarization in that direction. You're going to see my QRS complexes are changed, they're altered. Look how small these QRS complexes are in the affected region, right? So big differences, especially with an MI. This one's kind of right in your face, but I just wanted to talk to you about some of the differences. So the last thing we're going to talk about is a really interesting complication of pericarditis, which is a pericardial effusion or cardiac tamponade. And that's important because there are some interesting features on ECG as well. And so let's talk about what happens. So I'm going to redraw my visceral and parietal pericardium. I'm just going to draw it all one color here. My visceral and parietal pericardium with my pericardial fluid. And so remember that in pericarditis, why do we care about pericarditis? Well, pericarditis can cause fibrosis, chronic constriction of the pericardium, which can kind of hold the heart back from getting a good, nice fill and squeeze, right? Constrictive pericarditis. It also causes this inflammation, which allows for permeability. It causes an increase in permeability in cell membranes of some of these connective tissues and the surrounding tissues. And what that allows for is it allows for fluid to leak in to the pericardium, right? So we get leakage of fluid into the pericardium. And so we see the pericardium will expand and the pericardium will get really, really big and it'll stretch and it'll get full of all this fluid. So now instead of this nice small thin layer of pericardial fluid, we now have a lot of fluid. And so now my parietal pericardium is all the way out of here, right? All the way out here. And so this is called a pericardial effusion, right? This is a pericardial effusion where we have an effusion inside the pericardium. Why does that matter? Well, if it happens really, really fast and there's not enough time for the pericardium to accumulate or to stretch in accordance with the fluid increase, you can actually get constriction or kind of this bowing in to the heart, where this starts to tamponade the heart, and you get something called cardiac tamponade, right? And so we think of when you get return of blood flow back to the right side of the heart, it's a low pressure system, right? It's our venous return to the right side of the heart. And so you get something called, in diastole, essentially the right ventricle is going to collapse, get diastolic collapse of the right ventricle, and you can't feel the heart. And so in cardiac tamponade is this phenomenon where you have a pericardial effusion that occurs rapidly, and it constricts the ability, or it inhibits the ability of the right ventricle to fill, and ultimately, if the right ventricle can't fill, it can't get blood to the pulmonary vasculature to the left ventricle, so the left ventricle can't fill. So what are you going to see on the ECG when this happens? One, you're going to see tachycardia, right? You're going to see a sinus tachycardia. Why? Because we're in shock, we're hypotensive, right? Beck's triad, we're hypotensive, we're tachycardic. We've got jugular venous distension because we can't get those blood flow through the jugular veins back to the right side of the heart. So you get JVDs, people have big blown up blood vessels in their neck. And so the ECG, you're going to see tachycardia and cardiac tamponade. You're also going to see something really interesting, and it's called electrical alternans. You're not going to see this every time. Electrical alternans, alternating electrical signal, right? So electrical alternans. Why do we get electrical alternans? Well, this heart's beating fast. And now that we've got all of this fluid, in the pericardial space, the heart is not contained nicely. It's not like this nice glove of pericardium. So what happens is the heart can swing. And so what will happen is it'll squeeze, and then it'll swing, squeeze, and then swing, squeeze, and swing, squeeze. And obviously with every squeeze and every swing, each squeeze, there is our electrical action potentials that are going through the atria, through the AV node, down through our system, and depolarizing the ventricles, right? So it'll squeeze over here, and it swings. So electrical alternans is this interesting phenomenon where you'll have a QRS that's this way, and then the next QRS might be this way. And then you might have a QRS that's back this way, and then it'll be negative again. And it'll go back and forth and back and forth. And what is going on with that? It's registering the depolarizing forces that we just talked about. But the heart is changing position back and forth every single time. So, complication of pericarditis is a pericardial effusion. You can get something called cardiac tamponade, which is a clinical scenario, right, with Beck's triad. But in this case, the ECG, with a massive pericardial effusion, where the heart can move freely, what might you see? You might see some tachycardia if they're in tamponade, but you might see this electrical alternans feature. And I have one example. And so here it is. You've got this person is in a tachycardia. You can see the rate here. If I find this ECG, this QRS on the solid line, 300, 150, 100. So it's between 100 and 150, maybe 120 beats per minute, right? So they're in tachycardia. It's a sinus tachycardia. We'll just briefly, you can see P waves in front of the QRS complexes, right? So this is a sinus tachycardia. Given the clinical scenario, you're just wondering, I wonder what can be the cause of their tachycardia. Maybe they're hypotensive, they're in shock, right? Why are they hypotensive? Maybe their right ventricle can't fill. Maybe it's like an obstruction of blood flow through the heart. Are they in obstructive shock? What is the EKG going to tell us? Look down here at V5. And this is where it gets really interesting. Look at the difference in the amplitudes of these QRSs. You've got tall, short, tall, short, tall, short. We would call this electrical alternans. And so this is a patient that's got a massive pericardial effusion causing some tamponade, right? It's abutting that right ventricle, so it's pushing in and it's essentially causing diastolic dysfunction of the RV. What does that mean? That means diastole, when it's filling, it can't fill. That low pressure system can't fill because it's being impeded by all that fluid pressing, because the pressure of the fluid in this case is higher than the pressure of the venous return. And so now with all this fluid, the heart is rocking back and forth with every beat, and you get electrical alternans. So this is a great ECG example of electrical alternans, which can be caused by other things, but in this case, given the clinical scenario, right, the EKG is a tool for you. Given the clinical scenario, you could say this might be somebody who has a massive pericardial effusion or is in cardiac tamponade. And so that's kind of rounds out our pericarditis discussion. Remember pericarditis, it affects the pericardium. Remember that pericarditis, it affects phase 2 of that action potential, which is usually what allows for that ST segment to be nice and isoelectric and flat. But in this case, we get diffuse ST segment changes, we get ST elevation, we get some PR depression, we get the opposite changes in AVR. And so use the EKG as a tool in your diagnostics for pericarditis. Don't forget that, as part of the new organization on the channel, to go to the Patreon, sign up for free. I post an EKG challenge every single day. The goal of that is just to give you guys reps, free reps. I post the answers on the next day, and then ideally we'll go over those too. So I hope this helps, and if you have any questions, feel free to throw them down into the comments. Thanks so much for watching. Subscribe to the channel. We'll see you on the next ECG video. Have a great day.